Welcome to the fifth episode of the Evidence-Based Pediatric ME/CFS webinar series with Dr. Peter Rowe. This episode is Neuroanatomic Considerations of Pediatric ME/CFS. Dr. Rowe's longer bio is in the first episode, but I'd like to emphasize today his ability to see the connections, which this webinar series has attempted to lay out for listeners. During his career, Dr. Rowe worked on the forefront of connecting MECFS, then called CFS, with orthostatic intolerance, episode 2, and the association with connective tissue disorders, such as Ehlers-Danlos syndrome, EDS, episode 3. He's been helping to further the work with connections in mechanical and neuroanatomic considerations, episode 4, and now episode 5. Complex chronic illnesses are multisystemic. The person doesn't exist in a vacuum. Getting at the solution requires looking at the whole patient. My name is Bridget Collins. I am a person with pediatric onset myalgic encephalomyelitis, also known as insidious onset. I have been sick for over 30 years now. While I have many of the other considerations discussed in the Evidence-Based Pediatric ME/CFS webinar series, neuroanatomic considerations are ones that, so far, are not on my list. I am very pleased to introduce Dr. Peter Rowe, who will guide us through his work on this undercovered topic. For further insight into the patient experience, stay tuned for our lived experience panel discussion. Dr. Rowe, over to you.
Well, thank you, Bridget. It's a pleasure to join you all for another in the series of talks about pediatric ME/CFS. And today we're going to talk about a subset of patients who have neuroanatomic considerations. I'm going to list the key points here, and that is that a subset of individuals with ME/CFS, especially those who are extremely impaired, can have anatomic abnormalities that include things like Chiari malformation, cranio-cervical instability, Atlanto axial instability, and then cervical spinal stenosis, as well as tethered cord syndrome. And these sometimes require surgical intervention. Many of these anatomic problems can present with fatigue and orthostatic intolerance as prominent early symptoms, so there's often an overlap with ME/CFS. And connective tissue laxity, which we see in 60% of the adolescents with ME/CFS, is a risk factor both for ME/CFS and for many of these neuroanatomic abnormalities. You can have them without having connective tissue laxity, at least in the ligaments and the testing that we can do in the clinic. But being more hypermobile seems to be a risk factor. We find that for many of these problems, dynamic imaging, meaning imaging that's done with the patient in different positions, flexion, extension, rotating their head to the side, is usually required to make the diagnosis of instability. And these are not problems that affect everybody with the illness. So it's very important that we not over-test everyone, and that we as clinicians carefully select the patients for surgery, because we don't want unnecessary operations. So let's dig into each of those points. I want to talk first about Chiari malformation, then move on to a discussion of how patients with cervical stenosis can present, and then lastly with cranio-cervical and Atlanto axial instability. We won't have a lot of time to talk about tethered cord in today's session, but that can accompany all of these problems. So let's start with a 15-year-old that I saw a number of years ago. He presented with fatigue. He had previously been active in lacrosse and swimming, and then at age 15 had the gradual onset of fatigue. There was no infectious precipitant. As a swimmer, he noticed that his times in races were slower, and he was much more fatigued after exercise. As things progressed, over the next 4 months, he had to stop sports due to fatigue. He noticed that he would get exhausted after a hot shower. He was examined by a neurologist, and that was thought to be normal, and his brain MRI was called normal as well. He was a little bit more flexible than some, but had a Biden score of 3 out of 9. You need a score of 4 at least to be counted as hypermobile, but he was a little bit more flexible than some. So at this point in our clinic, we were doing tilt table testing. This was early on, and we brought the tilt table up to 70 degrees in this young guy. His heart rate went up 44 beats per minute in the first 10 minutes, and that provoked lightheadedness, nausea, weakness in the legs, and he was pale and sweaty. And his heart rate kept continuing to go up until the 20-minute point where you can see that blood pressure plummeted to below 50 millimeters of mercury with a slowing at the time of the hypotension in his heart rate. And that's consistent with neurally mediated or vasovagal hypotension. I will point out that over time, our use of tilt testing has gone way down, and primarily the main orthostatic stress that we put people under is a passive standing test for 10 minutes. That can often give us all the information we need to initiate therapy. It might be a bit less likely than tilt testing to confirm the heart rate changes of POTS, and it's less likely to cause the fainting, but it will usually provoke the symptom provocation, which is what we need in order to justify the start of therapy. So we began him as would be normal on an increased intake of salt and fluid, and he began a stimulant medication which acts as a vasoconstrictor drug. He had, as I said, a modest improvement, but was never back to normal. After 18 months of the illness, he was able to attend school daily, but he was always tired, and he said he felt weighted down. He was still interested in pursuing his sports, and so he switched to being the goalie in lacrosse, where he didn't have to run around as much, but he was exhausted after the games. And then over the next 6 months, he had a gradual deterioration. By 2 years into the illness, he had fine nystagmus on lateral gaze and a fine resting tremor. So nystagmus, for those who are not physicians or healthcare providers, is a rotatory movement of the eyes. He continued to decline, and he noticed that neck extension, turning his head back, would make him feel weak and lightheaded. And in fact, while painting the ceiling of his bedroom, he had 4 episodes of unusual stool and urine incontinence. He started noticing that he had numbness and tingling in the arms and legs and some difficulty swallowing. And at 26 months after the onset of fatigue, he also had not only the rotatory nystagmus, but decreased facial sensation to a pinprick test. So on repeat MRI, his cerebellar tonsils had descended 7 millimeters below the foramen magnum, consistent with Chiari malformation. Uh, MRIs of the cervical and lumbar spine were actually normal. So he had a suboccipital decompression, a C1 laminectomy, and at the end of the week after the surgery, he felt much more normal than he had in years. He was so normal that he probably made a mistake in going to attend the high school baseball game a bit too early, and that was followed by a day of vomiting and severe headache. And what had happened was that the cerebellum had fallen down below the area that it was put in. So he had cerebellar prolapse and needed a cranioplasty to put in more of a shelf underneath to support it. But after that, his nystagmus resolved, his orthostatic intolerance was much improved, and in college, he was able to swim for his college team. So Chiari malformation is part of a continuum of underdevelopment of the posterior fossa, the back of the skull. And it is traditionally defined as a herniation of the cerebellar tonsils through the foramen magnum, the hole in the base of the skull, by 5 millimeters or more. And the clinical manifestations are due to disruption of spinal fluid flow, sometimes backup of spinal fluid flow into the ventricles, and the direct compression of neural tissues. Keep in mind that if you've got a large foramen magnum, you might be able to have cerebellar tonsils down further than 5 millimeters without any direct compression of nervous system structures. And similarly, if you have a small foramen magnum, you might be having typical Chiari malformation symptoms with 2 or 3 millimeters of tonsillar descent. So everything needs to be put into that context. This is a slide that I put together showing in panel A normal MRI. And so here you see the cerebellum, the tonsils. If you draw a line between the clivus here and the occipital bone, this patient does not have any descent of the cerebellar tonsils shown here below that line. In slide B, there's not very much. You can see on slide A, there's a bit of spinal fluid in black on either side of the cerebellum, cushioning it from the bones. But in slide B, it looks quite crowded. And if you draw a line between the clivus and the occipital area, that intersects the cerebellar tonsils. This patient had a severely abnormal neurologic examination with clonus at the ankles. Uh, Panel C was actually the sister of one of our chronic fatigue syndrome MECFS patients. She was a cheerleader, and she noticed that when she was looking up at the crowd with the pom-poms up, she would get terrific headaches, and her neurologic examination was abnormal. You can see here that, again, the cerebellum looks crowded. The tonsils are triangulated. Sorry, let me turn back. Triangulated down below the foramen magnum, which is here, and she's even got this bend forward, almost what's called basilar impression of the brainstem that adds tension through the spinal cord. Panel D is the most extreme example of an abnormal MRI that I've seen in my career. And this is a young woman who had, again, the same kind of crowding, the triangulation of the cerebellar tonsils below the foramen magnum. The odontoid shown here is retroflexed and pushing back. So it's essentially narrowing the space that the spinal cord has to go through. She's got this forward bend and basilar impression of the upper part of the brainstem. And you can see here that the ventricles in this slide look way larger. So she had obstruction to spinal fluid flow that was also contributing to her symptoms. The next slide just shows you the line at the foramen magnum. Here's the normal individual, a healthy individual who has no cerebellar tonsillar descent. Here's a mild amount of descent, but a very crowded posterior fossa. And these patients had something like 13 millimeters of tonsillar descent, or 9 on this case. It's been known for a long time that people with Chiari malformation can present with fatigue and syncope. And it wasn't long ago that we learned or we realized that in 2007 that this syndrome of Chiari malformation could occur at a higher rate in people with hereditary disorders of connective tissue like Ehlers-Danlos syndrome. Dr. Millerat, who was one of the pioneers of Chiari work, wrote described a huge series of patients in 1999, and the headache in Chiari malformation is usually suboccipital at the back of the head. It can radiate to the front, and it's worse with any straining that, like a cough or playing a wind instrument or straining on the toilet. And it can get worse with neck extension, such as looking up. There can be some pain or numbness in the face and the limbs, and patients can have problems with weakness and coordination and swallowing, as was the case for the boy that I presented to you. Swallow dysfunction is much more common in babies who have Chiari malformation. In Dr. Millerat's series, chronic fatigue was present in 59% of those with a diagnosis of Chiari, and they can present with fainting. 12% had a positive family history, and connective tissue laxity was more common. Here's a paper on syncope as the presenting feature. So this was back in 1982, and then another paper with similar findings in 1991. The examination findings include hyperreflexia, often with a positive Hoffman sign, the nystagmus, like my patient had, sometimes double vision. We check a gag reflex in these patients, and sometimes it's quite striking to notice that as you push the Q-tip against the posterior fossa, there is no gag reflex. The Romberg examination can be abnormal. So can the tandem gait, where you're putting one foot in front of the other. And then there can be some facial reduction in sensation. So the proposed mechanisms for the autonomic dysfunction we see with Chiari are that you can get uh, compression of one of the vertebrobasilar arteries due to the transient increase in intracranial pressure when people are straining or doing a Valsalva. There can be direct compression of the midbrain ascending reticular system nerves. There can be compression of the cardiorespiratory centers or the sympathetic structures and some of the sympathetic pathways as they come through the foramen magnum, as well as deformative strain and adverse tension in the cord. And I've listed some references for the papers that have described these potential mechanisms. One of the best investigators, in my view, of this work has been Dan Hafez, a neurosurgeon who I knew in training at Johns Hopkins in the 1980s. Dan went on to practice in Chicago and then in Milwaukee, but he was interested in the fact that many patients being sent to him for evaluation who had a diagnosis of either ME/CFS or fibromyalgia actually had classical features of what's called cervical myelopathy or cervical spinal nerve compression. So he had a huge series of 270 patients that were sent to him with a diagnosis of fibromyalgia that probably included a lot that also had comorbid ME/CFS. And he found that 20% had cerebellotonsillar ectopia, meaning the cerebellotonsils were below the foramen magnum. And then 46%, as he measured the front to back AP canal diameter of the cervical spine, had what counted as cervical spinal canal stenosis, which is anything under 10 millimeters of spinal canal, and that was at C5-6. And so he looked at that using the CT in extension. It reached 45%. In the CT in neutral or the MRI in neutral, it was a little bit over 25%. And one of the things that he offered patients was uh, surgical treatment, and he had a group that he followed, some of whom agreed to surgery, others declined that option. Probably the ones who declined had milder symptoms. The ones who accepted the offer of surgery probably were sicker, but he looked then at the number who had improved at 1 year in the surgical group and the non-surgical group, and you can see that there's a significant improvement in fatigue, fatigue with exertion, concentration, headache, body pain, dizziness, and nausea. Now, this was not a randomized trial, but it provided a lot of evidence that there could be potential for improvement in patients who were carefully selected and had the concordant neurologic exam and radiologic findings. That led to a challenge from the group at Vanderbilt, led by David Robertson. And they claimed to have found no increase in herniation of the cerebellar tonsils in a group of patients with orthostatic intolerance. So they had patients coming to their clinic, which required for their studies a very high norepinephrine level, and it was a clinical research unit where patients were to be off most of their medications. So this was a different group than we might encounter in clinical practice. And they had a number of controls. Now, they selected people with orthostatic intolerance who had, for some reason, had an MRI, and they looked at controls who had had an MRI for a different neurologic group of symptoms. So the ages were similar, the degree of tonsillar depression was similar, and the percentage who had tonsillar descent looked equal on both groups. One of my favorite lines from clinical epidemiology was from David Spodek, which was that one has to read the clinical literature critically, if not biblically, he said, because what the conclusions giveth, the materials and methods taketh away. So here were the methodologic problems in that paper. So they had a total of 55 people with POTS in this very specialized autonomic clinic. all of whom needed a substantial increase in norepinephrine levels. So they were not characteristic of everyone with POTS, and only 42% had undergone an MRI. So for those two reasons, these guys were not representative of the entire population of POTS outside of this autonomic clinic. And the 46 controls weren't really healthy controls because somebody had thought they needed an MRI to investigate their neurologic symptoms. And then just a little bit of statistical analysis shows that if you have a result showing a 13% abnormality in 23 patients, the 95% confidence interval on that estimate is very wide. It goes from 4 to 33%. So I think this indicates a need for much larger studies, and our experience is very much more like Dr. Hafez's experience in a clinic where patients are coming hoping for improvement rather than hoping to be studied. Let's go on to look at cervical stenosis. We had published a series in 2018 showing that there could be improvement of what was otherwise undeniable MECFS, quite severe, following the recognition and the surgical treatment of cervical spinal stenosis. So here's an example of one of the patients from that study. This was a 15-year-old who had fatigue, lightheadedness, and brain fog. She was fine until age 12. And then after some sort of rotavirus infection, she developed fatigue, lightheadedness, tachycardia, cognitive problems, fairly infrequent headaches, actually. But by the time she was 15, she was unable to attend school due to fatigue. She had a free-floating anxiety, which she knew was irrational, but she couldn't control it. She had lightheadedness and brain fog and met criteria for POTS. She had a minimal response to any of the orthostatic intolerance treatments that I tried and any of the anxiety medications her psychiatrist introduced. And at age 19, so we've been examining her for 4 years, she had an intermittently positive Hoffman sign, which is elicited by putting a finger under the distal part of the middle finger and then flicking down, and you're looking for an involuntary contraction of the thumb and fingers, and this is said in a colloquial way by neurosurgeons to be the Babinski reflex of the upper limb. It usually means that there's something wrong in the cervical spine. So that gave us the rationale for doing her MRI, but we probably should have paid attention to the fact that her family history was quite abnormal. Her mother had congenital cervical canal stenosis and needed two cervical spine fusions, one at age 34 and the other at age 43 for degeneration of her cervical discs, and she also needed thoracic outlet syndrome surgery on 2 occasions. So this was by no means a normal anatomy in the mother. So we did a standing test in this young woman. She got headache, fatigue, and shortness of breath after just 5 minutes of standing, leaning against the wall, and we abbreviated the test at that point. She met criteria for POTS quite clearly. And this was the picture of her MRI. And what you see here is that here's the cerebellar tonsils. They're well above the foramen magnum, but CSF, spinal fluid in white on this image was really not apparent during this most of this segment of the cervical canal. And when you measure the AP diameter, this is usually 13 millimeters or more in healthy individuals. Anything under 10 millimeters counts as cervical spinal stenosis, and she was at about an 8 millimeter diameter from about this point all the way down. And as you follow the arrow, you can see that she had a small disc bulge at C67. I can bet that I have several small disc bulges in my spinal canal at this age, but they don't really cause any problems. However, for her, with a narrowed spinal canal, there was compression on the ventral aspect of the cord. The family knew a spine surgeon, Dr. Edwards, and he said to her at the time, I'm not sure I know anything about the fatigue and tachycardia you're experiencing, but if we don't replace this bulging disc, it's in such contact with your spinal cord that even a small whiplash injury could give you neurologic injuries. So he did the most conservative thing, the least invasive thing he could, which was to place in this area a an artificial disc without fusing the adjacent segments of the spine. So she, within 2 months, was able to exercise more, be much more active, took a job as a dog walker, and noticed a big reduction in her anxiety, her tachycardia, and her lightheadedness. Surgery had happened in November, and by the spring, she was negotiating with us that she wanted to take a summer job as a horse wrangler out in Colorado, which she was able to do, and she'd be up in the morning at 6, getting the horses ready for a trail ride, took people out on the trails, came back, helped brush and clean up the horses, and then helped with dinner. So she was able to go flat out full time. By September, she began a full-time 4-course load in college and was able to do 1 day a week in the Baltimore Inner Harbor shops for a few hours, and even do wedding photography 12 hours a day on the weekends. She has had full function ever since. This is now about 6 or 7 years ago, and she is now married and working for an international aid agency. This is her pre and post surgical circulatory responses showing complete resolution on the right of her POTS with only a 15 beat change in heart rate compared to a 64 beat change in heart rate. After her experience, we then got asked to see a woman, young woman who had to move back in with her parents, previously having been quite healthy and independent. But she had an abnormal neurologic examination. We looked at her MRI, and she had two very prominent bulging discs, and the spinal canal diameter was down to 9 millimeters at C5-6 and 7 millimeters at C6-7. And you can see that the spinal cord looked narrowed compared to the segments above and below, called myelomalacia. Her clivoaxial angle, I'll talk about in a bit. That's this angle here, was 124 degrees. So that leads to some strain across the spinal cord, and we weren't sure if that needed to be treated or not. When you look at a side view of here's her spinal cord surrounded by a nice amount of spinal fluid that was from up at this level, and then down at the point where the discs are bulging, you see this black disc pressing on the spinal cord directly. She and one other patient had really nice improvements, all three of them, in the heart rate increment when they stood, in the SF-36 physical function score between pre-op and post-op, and in their Karnofsky score, which is a measure of overall well-being, higher scores meaning more normal function. The third of the patients had milder disease. Here's her MRI. You can see that above the area of disc bulge, she had a 12 millimeter cervical canal. At the point of the disc compression, she was down to 8 millimeters. Her neurologic exam was normal. Above, you see an area above the area of compression with a normal bean-shaped spinal cord and a nice amount of spinal fluid around the cord. And here at the area of compression, you see the disc pressing down, and you can see an asymmetric squashing of the spinal cord. So the surgery involved placing these two metal areas on either edge of the surrounding vertebral bodies with an artificial disc in between. So we had a very nice improvement in this young woman. She was able to go skiing, and she was well enough that she could actually tear her anterior cruciate ligament skiing. So here she is being loaded into the ski patrol sled. But I have often said that if you can get your ME/CFS patients to the point of injuring themselves skiing, you're doing pretty well. We then found that she had a recurrence of her symptoms about 4 hours after the initial surgery, and again had met ME/CFS criteria, again had orthostatic intolerance. And we found out that what was causing this was the metal part of the artificial disc had slipped back into the spinal canal, causing again cervical stenosis. And you can see here that this metallic disc material was narrowing the canal. So she then needed a fusion to keep things together and again had a nice improvement. So this was a recapitulation of the symptoms of ME/CFS caused by the same kind of cervical stenosis that she had in the first place. And her scores, again, and preoperatively before the first surgery, then postoperatively they improved. Then she got worse when that artificial disc material slid backwards and then improved afterwards. And the same thing goes for her physical function score. And here we used a Wood mental fatigue inventory for cognitive function, where lower scores are better. Let's move on to talk a little bit about cranio-cervical and Atlanto axial instability. And here I'd like to again present a patient to give people a sense of how folks come in to the clinic with these problems. So this is a young nurse who described herself as unathletic as a child and had poor depth perception. She was flexible and able to do a lot of tricks like putting her legs behind her head while lying prone, and her feet were going past her head. She had tachycardia that started in adolescence with a normal EKG and echocardiogram, but she met criteria for POTS. At 22, she started immunotherapy directed at her seasonal allergies, but had really intense reactions every time the immunotherapy dose was increased, with itching and congestion and even throat closing. And the allergist would treat her with 5 or 7 days of a methylprednisolone course each time they increased the dose of immunotherapy. And 18 months in, she was still only at half of the full dosage that they had intended. She was working at the time full time in Atlanta as a bone marrow transplant nurse at the onset of her main ME/CFS symptoms in March of 2019 at the age of 23. She'd had a car accident 3 months before, but it wasn't a big deal and she didn't require emergency room assessment. She'd done a lot of rock climbing in the preceding year, but really there was no other clear trigger to these problems. Over the next 18 months, she would get exacerbations in symptoms of fatigue and others that I'll show you in a minute every couple of months. And they started lasting between 4 and 14 days at a time. And so by July of 2020, she was unable to continue working. When we looked at her initial telemedicine evaluation, this was during the pandemic, so we took our history by telemedicine. She had fatigue that was always present, worse with any activity, despite sleeping up to 16 hours a day, and she would awaken unrefreshed. As a nurse early on, she could work 2 nursing shifts, but then she'd need 2 days to recover. She had a lot of headaches that were bilateral and frontal at an 8 out of 10 severity, and she had a lot of pressure and throbbing behind her eyes. Headaches were associated with a lot of other symptoms: nausea, lightheadedness, numbness, and tingling. She had neck pain that was occurring daily, worse with neck flexion or bending forward, improving when she found a neck traction device that she could use over the door. And then with turning her head to the side, she would feel this grinding crepitus in her neck. And she said to us that her head and neck felt unsupported. Lightheadedness was daily, usually with postural changes. She felt heavy and weak when she was upright, and she had some nausea. Heart rate would be 140 beats per minute at work, which might be fine if you're working on a treadmill, but she was just doing her standard nursing duties. Blood pressure at times was in the 80s, quite low. She had brain fog that was daily and worsened over the preceding 4 months. Lots of trouble processing, finding the right words, especially in stressful situations. She had a lot of myalgias and muscle pains, especially with arms overhead postures, and couldn't carry heavy objects like a gallon of milk. She had some itching and facial flushing, and then a whole range of other symptoms, uh, problems with light sensitivity, night sweats, swallowing problems, right-sided numbness and tingling, shortness of breath, constipation, temporomandibular joint dysfunction, and then felt overstimulated and had a new onset of panic. And what we were mostly impressed by, along with that large series of symptoms, was this clue that she had the head and neck felt unsupported. That is a cardinal feature of cranio-cervical instability. So we said, all right, she's probably got hypermobile EDS. She meets the criteria for MECFS. We know she's got POTS. She had some irritable bowel syndrome, had seasonal allergies and possible mast cell activation syndrome given all of the allergic inflammation. She had evidence of a neurogenic thoracic outlet syndrome with the inability to put her arms overhead, TMJ dysfunction, and we suspected the cranio-cervical or Atlanto axial instability as well as anxiety. So this was just a list of the things that we were trying to work on. So we said, all right, let's have you continue on trials of medications for POTS, return to the allergist for more mast cell activation evaluation. Send us up your prior MRI, and in the meantime, try using a hard cervical collar. And then once we've done all that, we schedule the visit in Baltimore. So this is a picture of the kind of hard cervical collars that are available. This one is an Aspen Vista collar. The Miami J is another type of collar. The idea being that if you've got instability of the ligaments in the spine and you can stabilize that person, then there's less banging of the spinal cord up against the bony segments. So this was a picture of a fairly normal MRI of the craniocervical junction here. There's a bit more straightening of the cervical spine than you'd see in a perfectly normal study, but in which case you'd want the cervical spine to be a bit lordotic and have the appearance of the front part of a parenthesis, that kind of a nice gentle curve. This is the way that we look at the clivo-axial angle that I was measuring and talking about. This is along the line of the clivus, and this is a line drawn down to the back of C2. And usually you want a clivo-axial angle in the 150 to 170 range. So here's this individual's prior supine MRI. Her clivoaxial angle, if you draw this angle here, was 130 degrees. So there's likely a lot of strain as the cord goes through this area. The brainstem is bent forward, and there's a measurement shown on the upper right called the Grab-Oakes angle, drawn as a line from the clivus down to the back of C2, and you draw a perpendicular and measure the distance between that line and where the tissues end. So here's me drawing the line down this way, and then the perpendicular here measured 9.2 millimeters. It should be less than 7. Others say less than 8. But anything more than that suggests some ligamentous instability at the skull base. Here again is a picture of the clivoaxial angle from a paper by Dr. Fraser Henderson, one of the pioneers in this field. The idea being that if you've got a more acute angle, less straight, that there is increased strain across the tissues in the spinal cord, and gets worse the more abnormal that angle becomes. So in this patient, we thought, let's see what happens with the hard cervical collar. And she had immediate resolution of her headaches and neck pain. Now, I'll mention here that not everybody can tolerate the collar. Sometimes it presses on the jaw and causes temporomandibular joint discomfort, or it presses on occipital nerves in the back of the head. But if patients can tolerate this, it gives us a bit of an insight into what might happen with surgery, but also it helps confirm the thinking that this is a problem. So she had more energy. She was able to do consecutive hours of activities. She had a 50% improvement in her lightheadedness. Her sleep was better, and her speech was more fluent. She had another improvement in the sense of sensory overstimulation and photophobia. She was no longer having night sweats. And then just before she came to see us in the clinic, she thought she was supposed to take the collar off. And we got another piece of good information, which was within 2 days of removing the collar, she had a return of all of those symptoms. So on examination, she was an alert young woman. She did have hypermobility, like her early story of putting her feet over her head suggested. She had stretch marks over the hips, very stretchy upper eyes, velvety skin, flat feet. She had the piezogenic papules at the ankle that you see in the upper right picture that are all very consistent with hypermobile Ehlers-Danlos syndrome, and her reflexes were quite brisk with an increased spread of the patellar reflexes. So you tap the patella and also tap the skin 10 centimeters above the patella on the quadriceps area, and she still had a very brisk reflex. Her Hoffman sign was positive bilaterally, and she had an absent gag reflex. On the right side of her face, she had reduced sensation to light touch and pinprick. We investigated her for possible thoracic outlet syndrome with an elevated arm stress test or Roos test, and that was abnormal and provoked symptoms at an early point. Here's a picture of the eliciting of the Hoffman sign, and what you're going to see is, if it's positive, is this flexion, involuntary flexion of the thumb and first finger, and sometimes other fingers. We went on to dynamic imaging, and the supine cervical spine CT scan was done in flexion, extension, and lateral rotation. This allows the radiologist to measure movement in the frontal plane, which they call translation. And normally there should be less than 1 millimeter of movement between flexion and extension. She had 5 millimeters of movement. And then on the bottom right, you see the CT scan being done with a lot of lateral rotation to each side. And she had 43 degrees of right rotation and 45 of left rotation of C1 on C2, normal being less than 38 degrees, so showing a lot of ligamentous laxity. We do a seated cervical spine MRI in flexion and extension. I think you can see here that there's more contact of the odontoid area with the brainstem and the cord in flexion than there would be in extension. This is how the radiologists measure the C1 on C2 rotation. They get the uh, angle of the odontoid and then measure that against the angle of C1. And here's a diagram of this from one of the papers from Dr. Henderson and colleagues that I was part of, showing that if you over-rotate C1 on C2, this space in which the spinal cord sits gets narrowed, so there can be some compression. So that's one potential mechanism of symptom provocation. We've drawn a diagram or an artist's impression of this, that if you have excessive rotational movement of C1 on C2, the spinal cord is going to get sort of twisted and it will be under strain, as if you had a wet dish rag that you were wringing out. Another mechanism of symptom provocation might be that as the vertebral arteries are coming up through each vertebrae, and I'm just showing the artery on the one side here, if there's excessive rotation, you can get pinching of the artery at a couple of different points. So what happened to this young woman? Well, she had an occiput to C2 fusion. Remember, she had too much movement of the brain on the spine and then also excessive rotational movement of C1 on C2. So that is treated with this kind of procedure. And when there's movement of the spine on the occiput on the spine, that is called cranio-cervical instability. If it's just C1 on C2 rotational abnormalities, that's Atlanto axial instability. So her headache and neck pain resolved. Her head felt supported. She had much better energy and tolerance of activity and shopping. Was no longer as lightheaded with standing. And a number of her other symptoms improved as well, including clumsiness and grip strength. Everybody thought that her cognitive function and processing were better, and she was able to work part-time in a research job and was increasing gradually. Her wellness score was 80 at this time. Now, one of the problems when you have Ehlers-Danlos syndrome is this surgery cannot possibly treat everything that's wrong with connective tissues. So she has had continued problems with mast cell activation and some venous compression problems, but is still much better after the surgery than she would have been before. Dr. Henderson has spent a lot of time looking at the outcomes. Here's a paper that we did with him on patients who came in with refractory syncope and pre-syncope when they had Atlanto axial instability, and this showed some evidence of improvement after surgical stabilization. So here's the group pre-surgery in the white. 5 out of the 20 patients had syncope on a daily basis, and another 5 had I think it was maybe it's a bit more than uh, no, I think it was a total N of 20. Another five had multiple episodes a week, and another five had one a week. So, and only one person had never had syncope or pre-syncope. And then after surgery, look at how this curve shifts. Many fewer people having daily syncope, and many more having resolution of their surgery. So this was a highly significant difference. Dr. Henderson, or sorry, there's a paper by the Michael Phalings group in Toronto on craniocervical instability in Ehlers-Danlos syndrome, and this is a systematic review of the diagnostic maneuvers, including some of the ones I showed you, and then the treatment criteria for surgery, if people want to read more about this. So the clinical features that increase the likelihood that you're dealing with either CCI or AAI are that you have this report from the patient that the head feels heavy and unsupported. And I have to admit that I'm not sure I would have known what to do with that information if it was told to me by a patient 20 years ago. But now we zero in on the fact that this could be a ligamentous problem that often follows repetitive concussions or is associated with the laxity of the ligaments. They can have hyperreflexia on examination, an abnormal Hoffman, tenderness to pressure over the spinous process of C2, sometimes this reduction in sensory uh, in the sensation of pinprick in different dermatomes, and less commonly they can have weakness, problems with dysdiadochokinesis, and abnormal Romberg or impaired tandem gait. Again, emphasizing the importance of a fairly thorough neurologic exam. These are the indications for atlantoaxial instability surgery in one of the papers from Dr. Henderson. So these are patients who had to have severe occipital headache and neck pain, so a severity of 7 out of 10 or greater. Functional impairment, unable to do their usual activities, and a failure of more conservative measures like medical therapy and physical therapy. And with that, they had to have obviously the neurologic examination findings and congruent abnormalities on the dynamic imaging. And the point I want to make here, and this gets to the issue of careful case selection, is that you want to make sure that you're not treating the presence of excessive C1 on C2 rotation alone, or an abnormal clivo-axial angle, or an abnormal Grab-Oakes measurement. That's not sufficient to put people into the operating room. You really have to treat the patient and not the numbers. So we have a number of young patients who have abnormal C1 on C2 rotation in the 49-degree range. Remember, less than 38 degrees is normal. You'd think they were then in real trouble and at risk for major problems. Some of them have responded to standard physical therapy to strengthen the muscles of the neck. And so, and most of the patients who have not needed surgery really started off with better overall daily function anyway. So we want to treat the patient, not the rotational numbers or the spinal measurements. These are some slides from Dr. Henderson's paper on the, excuse me, the AA1, AAI, showing on the top, the Karnofsky score, where higher score is better. You can see a shift from the red before surgery to the Karnofsky score after surgery. The intensity of the headache pain also shifted to the left. That is, fewer patients with severe headache and also fewer patients with severe or moderate neck pain. Uh, no one should expect a complete return to completely normal function. Remember, this was a study done in people with Ehlers-Danlos syndrome. The indications for cranio-cervical instability surgery are the similar severe head and neck pain of greater than or equal to 7 out of 10 for at least 6 months. Symptoms of what's called the cervical medullary syndrome with altered vision, double vision, nystagmus, problems with hearing, dizziness, balance, vertigo, weakness, sensory loss, choking, and other kinds of dysphagia, trouble with speech, sleep apnea, and a lot of autonomic symptoms. And the neurologic deficits have to be congruent with the cranio-cervical instability, so lower cranial nerve deficits, weakness, sensory changes, excessively brisk reflexes, the Hoffman sign, Romberg, abnormal tandem gait, and so on. And again, we want to see failed non-operative management, so using a neck brace, physical therapy, isometric exercises of the neck, all kinds of other treatments. And again, these things need to line up with clear radiologic metrics. I was going to put in something on tethered cord here, that there are a number of symptoms one can test for with tethered cord. Often these are patients who have difficulty initiating the urinary stream. They can have problems completely emptying the bladder. They can have urinary incontinence or stool incontinence. They often have a history of terrible growing pains in adolescence. They can then have a number of symptoms related to decreased sensation in the perianal area, problems with bowel motility, and they often have to sleep in a more fetal position with their legs up towards the chest. Sitting with the legs fully outstretched can be a problem for them. And there's some others. And occult tethered cord means that there just aren't, that isn't an obvious abnormality on the MRI. Many of these patients can be confirmed to have this problem by getting urodynamic studies. There has been less published on occult tethered cord than on, say, Chiari malformation, but this is a growing area of interest and concern, and can lead to nice improvements in overall function. So back to the key points that we started with, and those are that a subset of individuals with ME/CFS, especially those who are extremely impaired, can have anatomic abnormalities as an explanation for their symptoms. These include Chiari malformation, cranio-cervical and Atlanto axial instability, cervical spinal stenosis, either congenital or acquired, and tethered cord syndrome. And sometimes these will require surgical intervention. Many of the anatomic problems can present with fatigue and orthostatic intolerance as prominent problems, so there's an overlap with ME/CFS. Connective tissue laxity is a risk factor for both ME/CFS and for many of the neuroanatomic problems. Dynamic imaging is usually required to make the diagnosis, and it's critical to have careful selection of patients for surgery in order to avoid unnecessary operations. I'm going to stop there. I just want to thank those who have made our work over the last 30 years possible. We've had a few grants, but most of the work of our clinic has benefited from the generosity of donors, including those from the Sunshine Natural Wellbeing Foundation, who have endowed a chair. The Boyce family and Allison Caldwell both have endowed funds that help us with operating costs. Our team consists of a physical medicine and rehab physician who deals with the adolescents who've grown up, Dr. Alba Azola. Samantha Lamont is a family nurse practitioner who can see people from all age ranges. Renee Swope is our nurse. Dr. Camille Broussard has helped us with study design and had worked with us for the last 2.5 years. Megan Swope is our research assistant. Rick Violand is my long-standing physical therapist collaborator. And Colleen Marden, for many years, was a volunteer research coordinator with us. We've been very lucky to have fantastic summer students, many of whom have gone on to careers in medicine. John Fan, Allie Johns, Marissa Flaherty, Jocelyn Ray, Samantha Jason, Erica Cranston, Megan Lauver, Maria Roma, Vic Cyberry, Lindsay Petrachik, and most recently Charlie Edwards. We've had people doing fundraisers, and at the bottom you see a picture of Emily Steffensmeyer, who organizes the Rose Research Runners program in State College, Pennsylvania, showing her with Rick Violand. And then many, many families and patients have contributed to the work that we've been doing and really have made this possible. So that's been really something I am particularly grateful for over the years. I think that's the last slide. I'm going to stop there. Thank you for your attention.
Thank you so much, Dr. Rowe. Now it is time for our lived experience panel. MEAction Maryland and Dr. Rowe's aim throughout this webinar series has been to give a holistic view of the person with ME/CFS and all its manifestations, from orthostatic intolerance, hypermobilities, laxities, mechanical abnormalities, and now to the neuroanatomical differences. As with all panels, not every patient experience is represented here in demographics or in severity. We are cognizant of this. We hope you will be as well. We are grateful to those participating on this lived experience panel and all of our lived experience panels. Kelsey, I'm wondering if you'd like to go first in introducing yourself and give us a little information on how ME and neuroanatomical presentations have affected you.
Sure. Yeah, and I'm grateful to be here. My name's Kelsey Martin. I was first diagnosed with chronic fatigue syndrome actually when I was 11 or 12 years old. And that led me to Dr. O a few years later. And kind of went on this journey together. I was diagnosed with POTS, NMH, and yeah, he really was a partner in trying to get to the root of things. Um, and some of those symptoms resolved, but others really didn't. I definitely struggled with brain fog. I'd have periods where fatigue was I was down and out for weeks at a time. I was very much in and out of school. And then I think I was in my early 20s when I had an MRI of my brain and C-spine, and it was for, I think, other symptoms along the lines of like maybe tinnitus or ringing in my ears. And that's when we discovered that I had this severe bulging disc in my neck. The doctor at first identified, I wonder if this could be compressing on nerves that impacts my POTS, so like my heart rate, blood pressure, and really pursued that from there and got connected with some surgeons who had studied this. There's the one surgeon I was referred to, I think, had done studies on fibromyalgia patients and um, maybe Chiari malformation, but also maybe spinal stenosis. And from there, went down the path of if we had this corrected, surgically corrected, would it alleviate my symptoms? So I'm really grateful that I had that surgery by a surgeon in Baltimore, Dr. Charles Edwards. Um, and from there, I mean, my symptoms were pretty much entirely alleviated. I started dog walking and I worked at an animal hospital like a few like short months after the surgery and really haven't slowed down since then. Yeah, so it really impacted my life and alleviated a lot of my symptoms.
You know, it's amazing. It's a small number of people for whom the surgery can apply to, but it can be so transformative.
Mhm.
Um,
Yeah, definitely.
11 is when I started getting sick as well. It
Mhm.
was chronic fatigue immune dysfunction syndrome
Mhm.
when I got sick, and it's just remarkable how many name changes we've gone through. Erica, would you like to go next?
Sure. My name's Erica Hayes. I came into myalgic encephalomyelitis via a COVID infection in November 2020. I was 36 or 37 years old, and um, really in the beginning it was just like orthostatic hypotension, which I got that diagnosis fairly quickly, and mast cell activation syndrome. And then after I was prescribed graded exercise therapy for my just overall functioning. That really made me decline, and I learned about myalgic encephalomyelitis um, around that same time of that decline. I started such severe symptoms that got me to a neurologist that decided to do an MRI due to similar things that Kelsey mentioned, like ringing in the ears, um, also just more severe collapses and tremor and just really bizarre neurological stuff. Um, so they did an MRI, and actually, my neurologist called and said, "It's all good." And I had already read the report that said I had Chiari. And I was like, ugh. So, yeah, I really learned about ME and Chiari at the same time. And that was about 9, 10, 11, 12. That was actually almost exactly a year into being sick. In my situation, like we found kind of the more serious thing potentially first with finding Chiari first. So then basically anything I could find that wasn't brain surgery was like good news, believe it or not. So, I mean, really, I'm at almost 4 years since I found the Chiari, and I still haven't had a surgery to fix one of these things yet. I'm still doing invasive testing to look at my different vasculature stuff and the intracranial pressure and elongated styloids and abdominal compressions. So since then, I've got a lot of other anatomical diagnosis that overlap with ME, and it hasn't been as easy as that initial one. I've had to really work to figure them out. So, yeah.
It sounds like light sensitivity, rain in your ears, photophobia are all things that providers should be aware of that are signs for neuroanatomical diagnoses. They're definitely high on the list of what they should be thinking. Jalen, would you like to give a little bit about yourself?
Sure, I'm Jalen Mercadel. I have been a patient of Dr. Rose for about 5 years now. Before then, I actually was a relatively healthy child. Nothing really wrong, just some weird things. I had really bad allergies, but we weren't a family that really like went to the doctors unless you were like dying or anything. I had like a really fast heart rate, but no one ever was like, it's serious or needs to be looked at. Grew up, normal, went to school, became a nurse, started working in critical care. Then at the end of 2018, we were hit from behind in a car accident, and I had whiplash. So my head jerked forward, and not even a couple weeks after that, started having symptoms. Actually, my first one was panic attacks. I had anxiety out of nowhere. Just felt like something was super wrong. Couldn't put my finger on it. And then all of the systemic things just started. My tachycardia got so much worse. My fatigue was crazy. I could sleep 14, 16 hours at a time and still wake up super tired. Um, so obviously started seeing specialists, just trying to figure out, what's going on. Nobody could really tell me anything. Ended up having like a stroke-like event at work and got to the ER, and they told me, we think you're having an anxiety attack. And 12 hours later, the neurologist was like, it's not, by that point, I still had like right-sided weakness. And my neuro exam was off, but they were just like, it's anxiety. We'll set you up with a neurologist if you want and scans if you want. And I was like, yeah, I can't feel the right side of my body. That would be great. I don't know a panic attack that lasts 12 hours. So yeah, that'd be nice. And yeah, by the time I got to neurology, they told me I had conversion disorder, which is a psychiatric condition, and told me that my brain was basically making up the symptoms or causing them. So yeah, I spent 6 months with psychiatry, and that was probably the worst part of all of it. And them trying to convince the other specialists that I needed a workup because something was really wrong. And from then on, I really deteriorated. So, like, my walking was affected, my speech became affected, started having choking episodes, my vision started being affected out of my right eye, just like basic things. And at that point, I made the decision to go to Cleveland Clinic to be a part of their national diagnostic program. And so left the state and they saw me and were like, "We have great news, you have POTS." And I was like, "Thank you so much. I know that. What about all of these other things, like how I can't walk or this other stuff?" And they were like, "Yeah, we have no idea. Like your scans look fine," which I was told before. Um, and really by fate, I find it that my mom, her boss at work, she works at the CDC. He worked under Dr. Rowe as a resident at one point and was like, "Hey, I know a doctor who works with POTS patients. Like, he could maybe just give you an indication of where to go next. Like, maybe just refer." And that ended up, it was 20 minutes. It ended up being 3 hours. And by the end of it, he agreed to take me as a patient. And in that Zoom call was when I heard like all the things I had been researching. So he was like, "I think you have cranio-cervical instability. I think you have CFS. I think you have this. I think you have that. I think you have this." By the time people, like I actually had a neurosurgeon who knew what those things were and were familiar with was familiar with EDS actually look at my scans, they were like, "Oh, you should be having like daily seizures by now. Like my spinal cord from that accident, but also the damage I did after that is permanently damaged. And my neuro exam like will never be the same. Like that's permanently affected. Never having any kind of surgery before. And then all of a sudden you're like, yeah, you're gonna have major surgery. It's going to permanently affect you for the rest of your life. Your range of motion will be affected for the rest of your life. Um, you no longer will be able to go back to nursing. You won't be able to do bedside. It was just a lot of hit things while also being diagnosed all at the same time. For me, it was really urgency. That's really just been the last 5 years over. Yeah, the urgency has kind of decided for me.
It's amazing how getting access to healthcare can feel like luck sometimes.
Yeah.
Yeah, because uh almost chance 20-minute appointment turned into the 3 hours that changed your life because, and I think we all have times like that, especially in getting a diagnosis for something like this, a neuroanatomical diagnosis. Does anyone else have part of their story that's like that?
Um, Access to care has been like extremely difficult for me because of various factors, mainly like cognitive limits, physical limits, financial limits. Whenever you don't find that one doctor that is like, okay, we're going to get to the bottom of this for you, you have to get like incredibly scrappy and you have to be so into every single report, pushing for every single test. So, like, uh, in the real world, I'll give you my example. So, like, we found the Chiari for me, but we weren't sure if that should be decompressed or not, or if doing anything like that with my Chiari would help me because I didn't have the typical Chiari symptoms, which is pain in the back of the head. I have other intracranial hypertension symptoms. Um, so we knew that I needed further workup, and trying to get that workup while I was here in Pittsburgh was very, very difficult because, you know, I had doctors out of state willing to help me whenever they learned about my case. But actually getting there, I mean, I became bedbound for a period. There was no way. Um, Other times it's just, you know, having to make phone calls or do actual appointments was way beyond my capabilities. Other times just juggling things cognitively and trying to figure out what the next step is and what are all the other things I need to rule out before I have brain surgery. Um, it's just been extremely difficult. And a lot of these like specialists that are working with, I also have Ehlers-Danlos syndrome. So it's very important for me to find doctors that are familiar with that because our bodies work completely different. Um, a lot of those doctors that are more familiar with EDS, they um, are pushed into like a private practice or whatever, and it's more financially difficult to even see them. Like the initial consults are, you know, $600,000. It's just, it's very, very inaccessible and honestly like emotionally taxing because you find some, for me at least, I keep finding things, everything I go to roll out. I think the only thing I've rolled out for sure is tethered cord. Otherwise, I keep rolling in everything to an extent. Like they're not all maybe the problem. Like maybe I'll have things more mild, but it's crazy.
Yeah, I mean, I feel like what I'm thankful for is the time that doctors took to really figure out what was wrong. I feel like I think I was thinking about this. If it were, yeah, I'm just really grateful. Like Dr. Rowe will spend that much time with his patients. Um, and he will spend years trying to get to the root of somebody's symptoms. So because it really took time and listening. I feel like he asks a lot of great questions, dives into, I mean, going as far back as like what you knew about yourself as like an infant, like if any, like he really just went way back into patient's history. Um, but then yeah, he also was such a great listener. Like he really took time to kind of listen and looked at it as like putting together a puzzle almost. Like how does everything kind of fit together? He looked at things kind of holistically. Um, I think before that, it was a lot of like referral to this specialist, referral to this specialist, and until a cardiologist actually did a tilt table test and diagnosed me with POTS and NMH. And then from there, like we knew the name Dr. Rowe. But yeah, like once I got in to see him, that really was like things changed.
I will say something I am privileged to have is in the last year, I qualified for a patient advocate through Medicare. And the patient advocate that I have been provided is on it. So I honestly don't have any more emotional capacity to keep finding things wrong with me and getting horrifying diagnoses. And she is doing that kind of stuff for me, getting me in with these subspecialists that are all over the US so that I can consult with them. I mean, I still have to find the money and do that, but she's taking the cognitive and emotional load off of me. And then I just need to somehow physically, financially show up. So that has been amazing. But again, that's an access thing. Like, so there's just a lot of hurdles.
Well, and you needed to know that that program existed
Right.
and do the work to sign up for. So,
Yep.
I mean, the other thing is insurance coverage. Because I think insurance would have been covered for, I was really young when I had my surgery, and it was basically between having a fusion and a disc replacement surgery. But like the fusion was something that I think that was covered by insurance. But the big concern was I was so young to have a fusion that really limited my mobility and would over time kind of wear down the upper and lower levels. Was just like not ideal. But the disc replacement surgery, we actually, it wasn't an emergency for me to have it. So I think we ended up waiting, and it was later that year that disc replacement surgery. I don't know if it hit it's like 10-year mark or something of study or whatever it was, but it was covered. So I mean, insurance coverage is like another huge thing for patients to, yeah, be able to access that.
and a lot of that again depends on if you have an advocate helping you, if your doctor is an advocate, because with prior authorizations for surgeries, for medications, there are so many hurdles in just getting things done that we don't have the energy or the ability to do ourselves.
Yeah,
So,
very true.
so how has your ME impacted treating your neuroanatomical illness, especially since many of our comorbidities have symptoms that overlap? Does this affect being able to discern what is ME and what is the neuroanatomical illness?
Yeah, for me, I think mine was a little bit twofold because I was diagnosed with chronic fatigue syndrome when I was 11 or 12. And that really stemmed from I was a super active kid, like very, very odd stomach bug that hit me, and afterwards just really deteriorated and did not recover, and had a super fast heartbeat, became very heat intolerant, low blood pressure, and so and chronic sinus infections. So just a lot of weird, wonky things going on from being a child who was relatively healthy and active to just being like couch and bed bound, like really had to stay horizontally. So that diagnosis came from, I think years of like working with a cardiologist, um, and the chronic fatigue syndrome diagnosis. But then once with Dr. Rowe, like we kept going down different paths to really figure out, okay, like being on a beta blocker, being on some of these medications like improves my symptoms, but not like I would still have weeks where I was down and out, like not able to keep up with schoolwork. I was in and out of high school. I wound up being in like home and hospital, and then ended up just getting my GED and trying to do college part-time. But yeah, so I think it kind of came where there's this like wall that was really hitting that we just couldn't really figure out where to go next. And that's where it really, the path that Dr. Rowe, he prescribed an MRI, and that's where that diagnosis came from. I had not, before that, really complained much about like neck symptoms. I had neck pain, and I remember, I think like a couple of years where I could not turn my head left all the way. And I noticed that driving, like I couldn't like look over my left shoulder, and just thought that came from position, posture, but also, yeah, I was a horseback rider. And that was a sport that I really continued doing throughout my illness. And I had a really bad fall, probably like, I'm trying to think how many years, maybe like 10 years before I had this MRI, and I had landed on my head. And so I had a really bad concussion, like could not remember anything. And they had put me in a neck brace at that time, but I was so young. Like they didn't look into like if anything else happened with my neck. But fast forward 10 years later, yeah, when my symptoms were just like really not getting better, and Dr. Rowe prescribed that MRI, it showed a severe bulging disc that had definitely been there for a while, and degenerative disc disease. So they think it could have been from that fall. But again, it was something that did not even think to explore that because I was so young.
You had an accident that was part of, and that we also had whiplash being part of the reason for our diagnoses. So there are not just ME and laxity being reasons for getting neuroanatomical problems, but there are also, a true mechanical cause that
Mhm.
needs to be looked at. And with children, sometimes we have the ability to bounce back.
Mhm.
We don't look at it then, but it should be continued to look on later at life.
Yeah, definitely.
Um,
I actually also had a whiplash concussion, well, two actually. And whenever I started looking into CCI, oh, I did roll out CCI, um, but I do have a little bit of AAI, like the way I actually hit my head whenever I flipped an ATV. It's really, really hard to pick apart what is what. Um, and it's so confusing that a lot of us have like these structural abnormalities, and then like accidents are involved, plus illnesses, um, viral and bacterial. Like a lot of us have so many of these random triggers that, maybe there's this initial trigger, but then this made it worse, and then this and this and this. And you could see why we overwhelm the doctors so easily. And like, oh, by the way, I have this genetic problem and I'm super floppy. Like, there's just so much. It's a lot. Like whenever I start thinking about like, oh, I should really work on core strengthening, or any type of little thing that I know would really help my body and benefit me. Since I have ME, I have to think like, Erica, are you able to bathe yourself when you want? If you're not adding in, whatever
Well, one of the
weirdness.
things I wanted to get back to that I didn't was you said that you were prescribed a round of graded exercise therapy, also known as GET, early on, which I assume did not help and caused you to do a little bit poorer.
Yeah, after I did graded exercise therapy, it was only 6 minutes on the exercise bike, which before I was sick, I was doing 30 minutes on the elliptical at lunch. So I didn't think of it, and like I had people warn me that that might be bad, but I didn't understand that it was like, oh, you permanently might be bad. So here we are.
Yeah, it's with the exercise piece, it's like I know, I mean, today I know like there are times that I can still get heart palpitations. So I don't know if that's like residual POTS, but if I'm training, they completely go away. And so I think there is like the confusion with symptoms. If you look at POTS, like I've read stuff about like Katie Ledecky and some of her training. And so in that sense, it's like prescribing exercise like might help in some way. But as far as the structural things and other things, it's like, I mean, yeah, you could be really kind of causing more problems.
As you suggest, Kelsey, there's a clinical distinction to note between myalgic encephalomyelitis and POTS. The hallmark symptom of ME is post-exertional malaise, or PEM, which is defined as a significant worsening of function following physical, cognitive, or emotional exertion. Exercise benefits some people with POTS, but it is counterindicated for patients with ME who experience PEM.
What I tell myself and like other friends whenever all kinds of online people that I try to help, like whenever they're early in their journey, if I can. And I tell them like a lot of like the ME symptoms I feel are protective. And that's why we need to listen to our bodies. Like if you feel like you can't sit up that well, you need to respect it. If you feel like that walk is pushing it, you need to respect it because while we hear that these things aren't damaging, there's something going on, and we know that from like the 2-day CPET that we're not oxygenizing things and whatever, and it can be really it's as quick as you screw it up, it could be 10 times as long to ever recover.
I call it like a life changing. You live your life very differently than another person. How your energy is allocated throughout your day. Getting providers to understand that. It's actually funny. I actually treat providers who aren't specialized in CFS as if they're just regular people off the street. Like if they ask me like, "Hey, what is CFS?" Like, and because the providers will say, "Oh yeah, we know what chronic fatigue is." You actually don't, because if I ask you, do you what they well, you have weeks where you don't feel great and you can't get out of bed. No, not quite. 24/7, 365, um, affects pretty much every action, every behavior that you decide to do, um, is chronic fatigue syndrome. So yeah, I just want to like, if I could pick anything out of everything we said today, like to send that to providers, yes.
How have other providers responded to your diagnoses? Do you feel like this had an impact on your interaction, your diagnoses?
I'll jump in there. Before I met Dr. Rowe, even after I've met Dr. Rowe, because like I said, a lot of my care has had to have been local, just because we financially just can't be up there with him all the time like that. Um, I will be completely honest here, and say that providers who actually look at your chart but see that Johns Hopkins is involved at all. So where Dr. Rowe, his clinic is, when they see that, it's an automatic, oh, okay, believable patient, will take you seriously. Any tests you ask for, anything you bring up, will take you a little bit more seriously. Um, if they don't see that, and I've had some providers who, like, obviously after my surgery, I rarely come across providers anymore who are questioning or like, where did you get, I've had providers say, where did you get diagnosed? Who diagnosed you? As if like they can't believe the diagnosis is true. And then before Dr. Rowe, definitely just either having providers who had never heard of the conditions I was bringing up, or if they heard of them, they were like, that stuff is so rare, it would be impossible. I had a provider, a geneticist say to me, there aren't any cases of African American or Black people having EDS, so we're not going to test you for that. It really just depends, but it seems like after care has started and treatment has started, yeah, people take me a lot more seriously.
I'm having a hard time. Like, I was actually just in Maryland a couple weeks ago to see a vascular surgeon to look at the abdominal compressions, and I do have nutcracker and May Thurner, and I I'm only 57% compressed in my iliac, and um my kidneys are only 30 some. So we're not recommending treatment at this point. And um I'm like, okay, do I need to put this on my chart? Because my chart already looks ridiculous. I don't know. So like literally one of my questions to my vascular surgeon is like, do my other doctors here at home need to know this? Because I already look ridiculous. Like my chart is just miles and miles and miles. And if I'm going to the emergency room for something like that could potentially be more serious, obviously, if it has anything to do, I want them to know. I want to tell everyone exactly what's going on with my body. But I know, like, I've been in the corners of Reddit where there are medical professionals that don't think that any of this is real. And I'm very, very careful with the things that I say.
I have 2 pages that I carry around with me everywhere: medications, surgical history, allergies, diagnoses, and just automatically hand that anywhere I go. It takes off so much of the digging around, remembering, oh, this was updated, oh, this wasn't updated. I keep it as Word documents that I actually put in my calendar to update it every 2 weeks. And just print out a new one instead of papers. That's too much energy, just keeping it in your phone or wherever. It takes so much of the mental load off of going anywhere new, or maybe an accident happening or an ambulance being called and people are like, what is, like some you could just say, look at the sheet. Um, Really helps a lot. So much of this stuff is so new. Trying to tell providers who aren't familiar with this, because they are educated in such a way that is so specialized. When they come across complex patients, I think cognitively it's easy for providers to say, oh, well, they're complex, but because they're complex, they're not my problem because they're not in my subspecialty, if that makes sense. So trying to explain to providers, like, even though you were educated in a way that is your subspecialty, really trying to branch out to look at me as a full person because I have multiple different systemic issues. So finding those kind of providers very helpful who are willing to do that, to step outside of their own education, even and educate themselves. Um, yeah, very helpful, because then that also helps you prioritize, give advice on maybe what things we need to start researching or looking at a little bit differently. I think because research has come so far, even in the last 10 years, I've had other providers like subspecialists and my gynecologist, especially with my vascular compressions, be really interested and having no idea. Like they were like, May Thurner syndrome for pelvic pain, for like that would go together. Never heard of it. So who's your surgeon? Who's your provider? Where are you getting this research? Now, but again, I think in a very privileged space. I recognize that because my access to care is so great now.
What do you think healthcare providers really need to know about being a person living with ME and having neuroanatomical illness? What would you like to leave them with?
doctors really have to take time and they have to listen. Like yeah, the 20-minute thing makes me nervous if my doctor's appointment is 20. I mean, and I'm relatively like now I'm relatively healthy. Like I don't have a lot of complaints about symptoms. So, but still, if I'm going in even for an annual, like that to me is shocking. It's like, wow, how can you cover everything in like 15, 20 minutes, you know? It's really not enough. That and also with seeing specialists, if you're having a bad day where your symptoms are flaring and you're really not feeling good, to go to a doctor's appointment, that takes a lot of effort for you physically to go to only be there for, 15 or so minutes is it's just unfortunate, like it's a lot that the patient is having to go through to like see a provider to only be given such little time. So there's also just a lot of fear going in and just for me, like I was a child when I was first diagnosed, and to me there's just alarm bells going off of like I remember as a kid, like I was afraid that I was dying, and so the sensitivity with that of just like it's a lot of us have anxiety, but it's just a very anxious experience to be so kind of consumed by what's going on internally and knowing something is wrong, being able to kind of see you as a human and being able to like look at everything and empathize with what you're going through is a huge thing. But I think whatever it is that kind of at now feels like there's a rush or like doctors have to get you in and out. It's not enough time. It doesn't allow them to, yeah, be
And
curious, like
a
you're
lot of
saying.
that is our system and not
Yeah.
them, which I completely understand, but we're all going through it together. And
Mhm.
since we are, we need to work together a little more on it.
Yeah, definitely.
I'll jump in. Actually, before I answer your question on what they should know, do you mind if I drop just a little advice
Definitely.
piece? Just because I heard you guys mention it about the time for providers. I found myself, I don't know, this is just being on the other side of it, not doing this with office staff, but when I actually get into the appointment with the provider, generally it's like my first consultation with them, like a new patient. And if I know I'm seeing them repeatedly, I've actually requested that my appointments be longer. It doesn't always work, but for quite a few of my specialists, because they know how complex I am, they've been willing to make that request work. So I get like 20, 30 minutes added to my appointment. And actually, I go over the office staff. So I just talk directly to the doctor to do that because generally the office staff are going to say, we have policies or procedures that we can't, but an actual physician will be willing to, knowing how complex you are, willing, and they too are sitting there with you for 15 minutes being doing this with you knowing they need more time. So and then in terms of what they should know, I would definitely just say, like I said before, the way they're educated is so subspecialized, and understanding that the patients that you're seeing, to be quite honest, if I was a provider and a patient came to me either looking into or had on their chart that they had ME/CFS or EDS or POTS or even mast cell, just one, I would view that patient as a complex patient in terms of needing to be viewed systemically. I hope whoever is listening as a provider understands like the care automatically at that point needs to be collaborative, not only with your patient, but hopefully, if you have enough time, depending on the system you're working in, with other providers. Understanding that your patient is educated. So the patient that's sitting in front of you is not coming to you about high blood pressure and getting on a beta blocker and going about their day. They're coming to you with a multitude of issues, updates that need to be worked on collaboratively. So it's not going to be a normal patient interaction.
Um, one of the things that I thought was most important for providers to know is like our quality of life. Like, I think it's important to understand that, just because I can sit here and do this with you for however long I won't be able to bathe later. I won't be able to cook dinner later. I won't be able to do all kinds of things. And this is actually me in a more moderate state, able to even take this time to do something like this. There have been periods where this is not possible. A telehealth appointment with my doctor is not possible. It would take too much. It would put me down for a week or two. And that is ME for whether they have, these neuroanatomical or neuroanatomical um, differences or not. Um, and then even like getting us to get the tests, those can be difficult. But I think a lot of times, my doctors see the absolute best of me because if I am not well enough, I'm not going to be able to do the appointment and I have to move it. And I'll know that usually like the day before. And so knowing that like what they're seeing, I'll get comments like, "Oh, so your biggest problem is headaches." And I'm like, "No, my biggest problem is I can't walk to the bathroom consistently. Like, I can't sit up for more than, however long. Like, 2 hours of me sitting upright is very, very bad. Like, I will be very, very sick." So, I think it's understanding how severely we're affected, even though we can pull it together for a minute to communicate with you and it looks like, okay, we're not that bad. Um, it's our quality of life. Like our quality of life is not great. And so we're willing to look at these gray areas that are still in research, some of them, and that we don't understand fully because we want very simple things like to sit and play with our kids on the floor for a half hour, like to wash ourselves every day. That would be great. So yeah, I'm willing to maybe, have you fish something through my veins and while I'm awake and like feel you in my heart and, you know, pull out part of my skull and whatever. If it's going to get me my life back, even just a 20%, that could be absolutely massive.
Well, I just want to thank you all and tell you how much I deeply appreciate you using your limited energy on this. Um, I don't know what it's going to cost you all, but I really do appreciate it.
Thanks for doing this.
Thank you.
Yeah, thanks for asking us. Yeah, and I really hope this helps.
Someone out there, some people.
Yeah.
Our thanks to all three of our panelists for the time and energy today talking about MECFS and neuroanatomical conditions. We appreciate your experience and your insight, and her repeated thanks again to all of the panelists throughout the series. And thank you so, so much to everyone listening. Please bookmark this episode. Please share with your colleagues. All 5 of our lecture episodes are now available at youtube.com/@MEAct Maryland. And please stay tuned in the new year for the transcripts and the slides of all the previous episodes to launch in our social media and under their original episodes in YouTube. Thank you, and we appreciate you all.